Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for this opportunity. I would like to start by thanking the organizing committee and thank you all for attending this session. Again, maybe similar to the previous excellent talkers before me, these are some challenging cases, maybe not that challenging, but more like interesting cases that I see in molecular hematology during signing out molecular NGS and other testing. As you know, molecular techniques has been changing over the last few years, and we just saw how Dr. Saeed presented excellently how these advances in molecular technique is expanding, the advances in technology also is expanding, the IT is expanding. So if you go back 10 years ago or 15 years ago, molecular used to be think as an ancillary test. So no one is interested to do, let's say, FLT3 or MBM1 or other interesting genes. All of these genes have become more and more important, and we are expanding our testing in the last few years because of the targeted therapy. Now, we should use always a comprehensive approach. So it's not just the morphology. Morphology still it's a critical, still morphology is the gold standard, but we need to have a more comprehensive approach, including morphology, clinical presentation, immunophenotyping, flow cytometry, karyotyping, FISH, and molecular technique. So we should think of all of the neoplasm and myeloid neoplasm, lymphomas, and others as a comprehensive, integrated approach for these cases, looking for the clinical aspect, looking for the morphology, and adding the molecular as supporting in these cases. With time, the role of molecular testing is increasing, so we are seeing more and more cases that can be diagnosed based on molecular from peripheral blood, for examples. The ultimate goal is to understand the tumor, you understand the biological concept and behavior of this tumor, and provide most accurate diagnosis and the best targeted therapy for our patient. Now, why we do molecular testing? What's our target? When we think about molecular tests, all of the molecular testing targeting either DNA or RNA. So we are looking for DNA or RNA changes. When it's one of the reasons why we do it is for rearrangement. So if you think about rearrangement, either rearrangement, physiologic rearrangement, like in somatic hypermutation, for example. We do it to see any changes in the B cell, how to fight the organisms. So we do this and we see physiologic changes like in IGH variable chain mutations or rearrangement on these genes, or pathological fusions like in sarcomas or even leukemias where we have several fusions. We're also interested in SMVs and small indels, so these are point mutation, either missense or nonsense mutation, or small insertion deletion, so we can detect this in the DNA or RNA. We also do copy number changes, so we can do it for duplication, amplification, or deletion and silencing. All of these will affect the function of the gene. So we are looking for this at the level of DNA or RNA, and we see the ultimate effect on the function of the DNA. What's the major indication for molecular testing? If you are a pathologist, why you send the test for molecular lab? So either you send it for diagnosis because there are some diagnostic entities that require specific mutations. So you need to send this sample to get the diagnosis based on molecular. Sometimes it's not the diagnosis. Sometimes you know this is acute leukemia, acute myeloid leukemia, but you send it for classification. So if you have seen the classification of acute leukemia this morning, most of the classification is now based on genomic alteration or based on FISH finding or cytogenetics. Sometimes it has a prognostic significance, so some mutation associated with more adverse reactions, and sometimes there is a targeted therapy, and in some occasions we use the molecular for monitoring, so MRD testing, and similar testing, so you can, if a patient in complete remission, you can do the test and see exactly how frequent is this mutation, and you can detect something at very low level. Targeted therapy or cryptic abnormalities, like in some cases that cannot be detected by karyotyping, molecular will help with that, with these cases. Dr. Saeed did a great job explaining several of these methodologies. If you want to summarize Dr. Saeed's presentation, there is no perfect test. So every test answers different question, and every test has a limitation. That's very important. So you hear always about new technologies, a new test adding to the menu, but none of these tests will replace. Every test here has significance. So conventional cytogenetics, very important. FISH is very important. Chromosomal microarray, optical genome mapping, targeted exome, whole genome, and RNA sequencing. All of them, they have values for MDS, MBN, AML, either as diagnostic, as follow-up, some of them used in relapse, and some of them used in MRD testing. All of these tests collaboratively provide most accurate diagnosis for patients. They are different in terms of resolution. So you may get one test positive, the other test is negative because they answer different questions. That's the most important concept. Every test has different use in the molecular lab. They have different turnaround time, cost is differently, sensitivity is differently, the coverage, some of them more comprehensive and some of them more targeted. Some of them include copy numbers, some of them only SMVs, especially with NGS. All of these are NGS targeted, exome, whole genome, all of this NGS based, even RNA sequencing are NGS based, but NGS is a technology that can design the way you want, so you can get different information based on NGS analysis. Genes involved in myeloid neoplasm, they shared between acute leukemia, MBN, MDS, eosinophilia. You can see most of these genes are shared, but there are some specific genes more common like JAK2 or CALR or MBL1, MBL. Some genes are more common in some entities, but in general we call them myeloid neoplasm because these genes shared between most of them. Some of myeloid lesions has also fusions like BCR-ABLs and others, and we have seen this during the acute leukemias talk today. This is a very important slide. This is the most important slide in my talk. This is the updated 2022 ELN guidelines risk stratification, and this is what the clinician use to decide therapy. So, and this is updated from the 2017 risk classification. So if you remember, we used to think of FLT3 ITD, we used to do the allelic ratio. And our oncologists always ask, we need the allelic ratio because allelic ratio can differentiate between favorable and intermediate risk. Now allelic ratio is no longer considered. So we don't have allelic ratio in FLT3 ITD. The reason, because it's difficult to standardize between laboratory and because we have the FLT3 inhibitors now. You remember previously we have the bioallelic CEBBA mutations. Now it's not biallelic anymore. Now we are interested in frame BZIP mutations. So it has to be in this domain, the BZIP domain. One of the other changes also, so now we think of MBM1 as favorable prognosis, but if you have MBM1 without FLT3, this is favorable. MBM1 with FLT3, then it will be in the intermediate category. If you have any of these cytogenetics abnormalities with MBM1, then it will be in the adverse. So cytogenetics adverse will always trump the MBM1 mutation. There are some other changes. Now you can see these genes that has adverse effects. So all of these are genes detected by NGS, and these are usually seen with AML, with myelodysplasia related changes. A complex karyotype now does not include cases with hyperdiploidy. So hyperdiploidy is no longer considered complex karyotype and no longer part of the adverse reaction. So why we do all of this molecular testing? Because it's informed therapy. Therapy is based on molecular. We do molecular testing and NGS not because we are just want to know the finding, want to know what's the mutation. That's good, but not the main reason. We would like to provide the targeted therapy, the most accurate therapy for patients. And this is an old slide, but you can see that based on the molecular finding, the patient will receive different therapy based on what we decide present in this patient as pathogenic mutations. When you interpret the NGS, there are several caveats for interpreting the NGS before we go through the cases. So one of them is very important to understand the panel, how the panel is designed, what's the gene covered, because every NGS panel is different, and I think Dr. Saeed also shows the difference between different institutions. It's all of them, they test for NGS myeloid, but different panel, different genes included, different coverage, different quality metrics, sensitivity, specificity, lower limit of detection, all of these are different. So you need to understand the limitation for every test. Quality of sample is very important. If you have a bad biopsy, you cannot give a diagnosis under the microscope because the aspirate is limited or the biopsy is limited. The same thing with NGS. If you have a bad sample, you can get a false negative or you get a failed result. Very important to understand the difference between somatic and germline mutation with the NGS analysis. Variant allele frequency is very important to know if this is a dominant clone or subclonal process. Variant classification, so not every mutation are the same. Some of them pathogenic, some of them variant of unknown significance. It's very important to understand the concept, and you need to know if your panel is single gene versus multiplex testing. This is our panel at King Faisal Specialist Hospital. It's basically the Oncomine myeloid panel from Thermo Fisher with around 69 genes, some of them hotspot, and including also the fusions analysis. So let's go through the cases. This is the first case. So this is a 63-year-old patient with anasarca, fatigue, anemia, thrombocytopenia for 6 months. Now the patient has splenomegaly, so clinically he has a lot of abnormalities. This is the CBC. Definitely there is some anemia and thrombocytopenia. There is no circulating blast. The aspirate was limited, so the aspirate was not that helpful. Dry tab, no good aspirate. This is the biopsy showing normal cellular, no evidence, no clear evidence of dysplasia. We always like to assess dysplasia on aspirate. There is no increase in blast, no aberrant blast population. FISH is positive for 20 deletion and 5 deletion. So basically the morphology was within normal limit. There is abnormalities in the FISH result. When we receive the myeloid NGS, there is multiple mutations. So there is IDH2 mutation, SRS2 mutation, CBL and KRAS, and all of them at good allelic frequency, 46, 51, and this is the IDH2. This is what we call the integrated genome viewer. So this is the reference sequence and the reference amino acid, and you can see there is a mutation here in IDH2 changing the amino acid structure. So in this case, the IDH2 associated with the clonal hematopoiesis of undetermined potential only if the patient is healthy. So if the patient is symptomatic, then you cannot call it CHIP mutation. It's an early event in leukogenesis, frequently increased with age, associated with NPM1. IDH2 is considered a favorable outcome, and because we have the IDH2 inhibitors. On the other hand, SRSF2 is associated with poor outcome. It's part of the spliceosome structure. So basically having a multiplex mutation or multiple mutation like this case will make you think this is definitely not normal. Even if the bone marrow morphology is normal, this is very high. This patient definitely has something like MDS or others. And repeat biopsy in 3 months shows full bone dysplasia, and aspirate was full of dysplasia. So it's just a matter of early diagnosis, so, or sometimes limitation of the samples. If you have limited bone marrow biopsy, then maybe the NGS will help you, as in this case. Next, this is a 59-year-old female presented with pancytopenia. As you can see, there is leukopenia, anemia, and thrombocytopenia. White blood cells, there is no blast. The bone marrow aspirates, there is decrease in myeloid erythroid cells with full maturation, occasional dysplastic megakaryocyte, but it's not at the level to call it MDS. So there is slight touch of dysplasia. Biopsy hypocellular, which we don't see usually with MDS, hypocellular bone marrow with decreased myeloid and erythroid cells, full maturation, occasional dysplastic megakaryocyte, again, not at the level of full dysplasia, no dysplasia in erythroid or myeloid, flow cytometry, no aberrancy, FISH was completely normal. When we did the myeloid NGS, it's only positive for DNMT3A at 10%. So this is a pathogenic, not the most common mutation that we see, but again, at 10%, not that high. DNMT3A is associated with CHIP, so it's one of the very famous genes. There are 3 genes that are well known to be associated with CHIPs. There are many genes associated, but 3 common genes, the DNMT3A, and the TIT2 and DNMT3A and ASXL1. So ASXL1, DNMT3A, and TIT2, they are associated with CHIP. Frequency increase with age. If you see it with MBM1, with FLT3, with IDH1, then you start thinking of MDS. Prognostic significance is not consistent. Poor prognosis only if you see it with other mutation like MBM1 mutated or FLT3 mutation. There is no value in MRD testing, and that's very critical. If you see DNMT3A later, after the patient in remission, this could be something clonal but not related to the leukemia. So in this case, what do you think? We have DNMT3A mutation at 10%, and otherwise almost negative bone marrow, a touch of dysplasia. So this could be a CHIP, especially that the allelic frequency is 10, and could be a real mutation. Again, CHIP, we see it in healthy individual, but with time, this patient may develop MDS later. So I don't think the physician will act on this mutation alone. Next, this is a 56-year-old with refractory anemia. CBC shows clearly there is anemia, platelet count and white blood cells are within normal range, no increase in blast. The bone marrow shows hypercellular bone marrow with prominent myeloid proliferation, monocytosis, mild dysgranulopoiesis, and dyserythropoiesis. So the suggestion of the diagnostic morphology is CMML, chronic myelomonocytic leukemia, and FISH was normal. So we did the myeloid NGS. We found TIT2 mutation, truncating loss of function at 63%, SRSF2 mutation, very common, this is P95L. MBM1, this is type 1, type A duplication, and KRAS, also a hotspot. All of these are hotspot mutation, and the patient, based on this, receive chemotherapy, because this is not a regular CMML, this is an advanced CMML, especially with MBM1. So once you see MBM1, in fact, now it's become a diagnostic entity within the WHO, so AML with MBM1 mutation, according to the WHO, you don't need even a blast, but I don't think, it will be difficult to call something acute myeloid leukemia with 0 blast. That's difficult. So the ICC would require at least 10% blast. But even if there is no blast, wait for a few months, it will become acute myeloid leukemia, because the MBM1 is diagnostic for acute myeloid leukemia. So even though the morphology shows no blast, CMML, but finding this mutation, and again 6 months later, you can see that especially the leukemic clone respond the most. So the MBM1 and KRAS, they are very close in terms of allelic frequency, and they become to 1%, 1%. That responds the most to the chemotherapy. This is the leukemic clone compared to the other clone, which used to be CMML. So the 63% and 48%. So the lesson from this case that some mutations like MBM1 showing you that this patient is transforming very fast to acute myeloid leukemia. This is some information about MBM1 mutation. It's very common. It's the largest entity in AML. If you have NBM1 with FLT3, it's a good prognosis. Without FLT3 mutation, it's a good prognosis. With the FLT3, to become intermediate prognosis. The good thing about NBM1 that we can use it for MRD testing, and this is also available at our institution. So you can do NBM1, especially type A, B, and D, the most common types. So 95% you can detect up to 1 in 10,000. So you can follow these patients with NBM1 mutation. Case for a 55-year-old male, known case of hypertension, hyperlipidemia, ischemic heart disease, and all of the diseases seen in elderly individuals, heavy smoker. Now the patient has thrombocytosis since 2020, and also there is hepatosplenomegaly. White blood cells, or CBC, shows increase in everything. So pancytosis, there is leukocytosis, erythrocytosis, and platelet is 1.5 million, so very high. Interestingly, the patient also has 11% eosinophils, so almost 2,500 cells eosinophils. Patient refused bone marrow biopsy. We followed him several times. He doesn't want to do bone marrow biopsy, so they send blood samples for myeloid NGS. And this is what we found. We found JAK2 mutation. JAK2 is well known, associated with MBN, and can be seen in other myeloid neoplasm. But also we found the FIB1 like 1 BDGFR alpha fusions. So this is the fusions commonly seen with hypereosinophilic syndromes, basically due to deletion of CHEK. So CHEK, all of this is a chromosome 4. So it's for deletion within chromosome 4. If there is a fusion by FIB1 like 1 and BDGFR alpha, the CHEK2 will be deleted, so you don't see it here. You see this is the normal, you see CHEK2 between them, and here deletion, that means there is a fusions. So this fusion is characteristic for hypereosinophilic syndrome. It's well known and associated with the response to TKI. This patient also had JAK2 at very high allelic frequency. Interestingly, JAK2 and BDGFR alpha work in the same pathway, so that means this patient has a different hit at the same pathway. And now the new WHO, they changed the name of this disease. It became myeloid and lymphoid neoplasm with eosinophilia and tyrosine kinase gene fusion. So this is the new name. The good thing for BDGFR alpha, they respond to TKI like imatinib. This patient also had JAK2, so he's also will be eligible for JAK2 inhibitor. So this is one of the usefulness for molecular test. Even without a bone marrow, we found the diagnosis, and the patient is eligible for 2 medications.
3 minutes more, doctor.
Okay. This case, this patient has, well-known patient has myelofibrosis, so we know that. Now he come to us with 5% blast. So there is fibrosis, now there is a blast. We would like to see how is the molecular finding. So there is JAK2, which is associated with myelofibrosis, we know that. But there is also IDH2 at 36%, DNMT3A at 44%, and MBL. So with JAK2, so we always think of MBN has either JAK2, CALR, or MBL. This is not the common MBL, but it's also reported to be pathogenic, loss of function. So this patient has 2 mutations associated with MBN, but also has IDH2, and IDH2 is one of the more aggressive mutations. If you see it in myelofibrosis, it's associated with fast progression. So IDH2 and other genes, there are genes, if you see it in BV, associated with worse prognosis, gene with ET associated with worse prognosis, and all of these genes, if you see it with myelofibrosis, associated with faster progression for acute leukemia. And this is exactly what we see in this patient, because the blast is around 5%. This case, just quickly, this is a patient, 6-year-old boy, T-cell lymphoblastic lymphoma. His younger brother, so he's 6 years, younger brother also died from T lymphoblastic lymphoma, so there is something in the family germline. The patient, after completing therapy for T-cell lymphoma, he developed acute myeloid leukemia. So there is something in this patient. You think about something germline. So testing by whole exome sequencing, we found Lynch syndrome mutation in MSH2, one of the mismatch repair protein, and also the amyloid shows RUNX1 mutation at 47%. The lesson from this case is to do germline testing. So there are a lot of germline germline predisposition mutation that's seen. If you do germline testing in our institution, we expose all of these patients to whole exome sequencing. So any patient with cancer, we prefer to do whole exome sequencing if there is suspicion for germline mutation. And ideally, every patient with cancer should receive whole exome sequencing to rule out germline, because you can prevent this in the families. RUNX1 mutation, also one of the common germline mutation that can be seen in some cases. Also, there is a trend now to do whole exome sequencing for donors. So if you are going for bone marrow transplant, it's good to make sure that the donor don't have any mutation for late onset genetic diseases. So this is what we do right now. We expect the result to be negative, but we would like to screen this donor with whole exome sequencing. In summary, myeloid neoplasm are heterogeneous. We know that. If they are heterogeneous in morphology, heterogeneous in the prognosis, in morphology and clinical, that means they are also heterogeneous in terms of genetics. Morphology is the gold standard. Myeloid NGS is become a standard of care. So every patient with leukemia that come to us will receive myeloid NGS, including full DNA and RNA sequencing for mutations and fusions. Whole exome sequencing should be offered for every patient where germline mutation is suspected. Similar to morphology, NGS depend on the quality of the samples. Knowledge of biological information about tumor is very critical in understanding how the tumor behavior and deciding the targeted therapy. And thank you so much.